Good. So I'm going to just share a few kind of pearls on the FRCS exam, otology within it, and then basically go through like a very, very quick signposted whistle-stop tour through the subspecialty. So it'll be unrealistic to kind of teach you everything in one evening, but what we'll do is at least kind of talk through what you need to go away and know, how to answer questions well, and some tips on that. And then we can sort of slow down on some of the more tricky bits. And feel free to ask questions, and Alex, Livy, and Ben can sort of field them and interrupt me as needed. So, look, the first thing to say is the learning curve in otology is really shallow, and then it's really steep, and it's quite, it's quite typical to reach ST7 having sort of done the occasional tympanoplasty or seen it and then not done any for ages, and suddenly you get to near the end and you sort of think, is this like I can just about do a tonsillectomy and suddenly I'm taking the FRCS exam. So just to reassure you that it is normal to feel like that. It's normal to wonder whether this is the moment where you're about to be found out as a fraud and it's all going to come tumbling down. But when I was preparing this talk, I looked back on my revision group's WhatsApp group to see where we were at when we started, and it was stuff like this basically. These are genuinely the sort of the things we posted. So don't be, it's normal basically to feel out of your depth, particularly in otology. It's a very passable exam, particularly once you've got past part one. Part two is eminently passable. You just need to give yourself plenty of time, pace yourself. And actually what you find is you start off rapidly trying to learn everything, and then actually with 2 weeks to go, you sort of feel like, actually, I'm ready and I could do this exam today. For those of you that are a bit further away from preparing for this, in terms of the format, you get 4 banks of 30 minutes vivas. So otology makes up one of those banks of 30 minutes. And within the 30 minutes, you get 6 5-minute questions. Okay. And it's basically that's what we're going to focus on mainly. But each question is its own score. So even if you have a mare, the key thing is to not fall off the horse completely, but to keep going and recover, because you can make the points back. In terms of the room, it's basically like this. Like, it's a busy version of this. You're not in some kind of private, quiet room being vivaed. You're in a massive hall where everyone else is getting vivaed as well. And it's quite sort of useful to visualize what that's going to be like, because otherwise it can be a bit disconcerting if you're not expecting it. But in terms of each question, basically you'll typically be given either a video or a picture, and you'll have an introductory question just to sort of ease you in it. Don't take time on it, just answer the question factually. This is an otoscopic picture of a right tympanic membrane with evidence of middle ear effusion. So you want to get through that quickly. Then there'll be a focus question like, what do you expect the audiogram to be? Probably about 30 to 40 decibel conductive hearing loss. And then there'll be a pass-fail question, something like, talk me through the nice guidance on the management of middle ear effusion in kids, or something like that. So, the key is to learn to deliver your answers very swiftly and without too many clunky pauses, in a way that you can actually get through this in the first minute, actually. And then you can you might see the examiner just kind of sit back and start thinking, well, where will I take this viva? And because of that, it can sometimes feel like, they'll keep asking and asking until the 5 minutes is up. And so it's quite normal to come out of the viva thinking, what on earth, I feel like I really messed that up. And actually you probably haven't. I think people struggle to score points where they take time to get past the first few questions. So you can help yourself by practicing to give swift, slick replies so that you get to that point within a minute. And the scoring is a bit like this. So, you should reach 6s in most of them, and you want to be aiming for 7s and 8s, ideally, to give yourself some buffer. Now, the other thing to say is everyone has it's an easy pitfall to underestimate the clinical stations, because everyone thinks, well, I know how to examine a patient, but the point is that these are actually Vivas in disguise. So you get 2 banks of 20-minute sessions. So otology and peds will be in 1 20 minutes, for example. But these are Vivas in disguise. So you will have you'll suddenly be presented with a patient with which you have not taken a history. So you have no rapport with that patient. So it's a completely artificial situation. And suddenly you're asked to, comment on this person's nose when you've not even had a chance to say hello to them. So there's no harm in just having a little chat with the patient, just to kind of develop a bit of a rapport and say, do you mind if I talk about you? Do you mind if I examine you? You can be easily thrown off otherwise. And these are harder than Vivas because there'll often be some patient who's had some irrecognizable operation, and of course you're not given the details. You'll just be told this patient has a scar. What sort of operation might they have had? So you don't have an operation note, you don't have the history, and then you might be asked to look in their ear, and you get one shot in that moment to look in the ear, decide what you've seen, and come out again. Unlike a photo where it's on the screen for you to think about it again. So don't underestimate the clinical stations. In terms of prep, so when I was preparing for this, kind of video meetings were a bit novel, and they're obviously so normal now. But working in teams obviously makes a massive difference. Commit to improving each other, share resources. There are lots of inheritable resources from the group before you that get handed down. And you can, the beauty of video calling is you can do this, and I'd encourage you to make links with your parallels in other parts of the country, because you'll get a different perspective on things by doing that. Okay, so I'm just going to do a whistle-stop tour through loads of otology topics. So it's important to learn, obviously, the otology examination. I won't dwell on that. Here's a topic that is tricky because you don't see it very much in training. Okay, but this is going to be a question about newborn hearing screening, and this, of course, is otoacoustic emissions. So the thing about pediatric hearing as a topic is that it's worth understanding what is an objective test and what is a subjective test. So an objective test is a test which doesn't rely on the patient's response. It doesn't rely on the patient understanding the test and responding. So the most commonly used objective tests in pediatric hearing are transient evoked otoacoustic emissions and auditory brainstem response, both of which are used in the newborn hearing screening program. Okay, so be able to understand. If you've had children, you'll have seen this on your own kids, but babies tend to have otoacoustic emission testing at bedside, ideally before they've left hospital. It involves a probe in the ear, a series of broadband clicks, and you're measuring the cochlear microphonic. And that's a screening test. So it gives you a clue that the child may, but may not, may be born with a permanent degree of deafness. And so they're referred on. Okay. And ABR is more frequency specific. And it's worth being able to explain the 2 different pathways. So the well baby pathway and the at-risk baby pathway, and what risk factors would put a child from the well baby pathway into the at-risk baby pathway. Okay, and the frequency of pediatric deafness is about 1 in 1,000 at birth, rising to about 2 in 1,000 by teenage years. Okay, so up to 5% of babies fail screening, but only 1/10 have a permanent hearing loss. Okay, here's another test that you just never see in training, do you? You request the audiogram and it comes back, but actually this is visual reinforcement audiometry. And the way it works is that you're playing a sound in so that the child moves to the sound, and then they get given a visual reward, which is that banana in pajamas figure. And once the child gets that visual reward, then they know that the next time they hear the sound, they're going to turn to get that visual reward. That's called conditioning. So you condition the child, and then you can then use use the fact that they're conditioned to the test to test at different frequencies and volumes. So it's important to know what age appropriate test is suitable for a given age. So below 6 months, you're generally relying on a broad behavioral observation, eye tracking, etc. From about 6 months onwards, you can start using visual reinforcement audiometry. And then around 2 years old, we move to play audiometry. So play audiometry is where the sound is played and the child is asked to put the toy in the box, sort of thing. So it's less resource intensive compared to visual response audiometry, which typically needs 2 audiologists. Okay, and then from about 3 to 4, you can start using the classic pure tone audiogram where you ask them to click the button. Okay, it's worth knowing, if a child is born deaf, what other etiological investigations are necessary, because remember that a proportion of children who are born deaf will have a deafness that is syndromic, and so the investigations are targeted in that way. They do vary by region, so I think you can talk about what happens in your experience, but typically family audiograms, ECG, ophthalmology, and a CMV screen are done in pretty much most places, and then the rest of it is all dependent on the rest of the history and parental risk factors. In terms of congenital loss, it's worth knowing that about 50% is genetic and 50% is environmental, of which a proportion of that you'll never prove the cause. So it's worth just knowing some causes of syndromic and non-syndromic hearing losses, and some common environmental causes of congenital deafness. Okay, all going all right so far? I can't see the video, but Alex, you can give me a thumbs up if all okay. Okay, great, good. So here's another condition that you don't see very often in clinic: microtia. Okay, so how would I answer this? Okay, this is a clinical photograph of a child's left ear. There is clinical features consistent with microtia, and the considerations revolve around cosmesis, hearing rehabilitation, whether this is part of a syndrome, and perhaps less so, is there any cholesteatoma? If you can sort of deliver that answer and signpost that you know the issues, you're already doing really well. Okay, and then they might go into asking you different aspects. So in terms of the cosmesis, loads of people learn the different grading systems. In reality, my experience of the exam is you don't really get asked a lot about different grading systems. Everyone loves learning them for the exam, but in reality, they're not. There's not a lot of time to demonstrate your knowledge in that, and quoting papers and things like that. It's not really that sort of exam. It's an exam where they want you to do the basics well. Okay, so you should consider the fact that this child is likely to have a maximal conductive hearing loss, although the nature of their loss will also depend on their inner ear anatomy as to whether they have a purely conductive or a mixed loss. It's worth being aware that bilateral microtia is a more emergent condition where aiding with early aiding with a soft band is particularly crucial, although we do also advocate early soft band bone anchored hearing aid use even in unilateral. In terms of the cosmetic, you've got options of autologous rib reconstruction and bone anchored hearing prostheses, and the plastic surgeons will usually wait until the child's about 9 or 10 so that they can be part of that discussion as to whether that's what they want to do. And some kids will decide not to have reconstruction. So some parents will choose hearing rehabilitation early and cosmetic later. Some kids have everything later. It's just the point is it should be managed in an MDT setting. It's worth just knowing some of the syndromes associated with microtia. So Treacher-Collins, Goldenhar are the sort of two big ones, Charge and 22q as well. Okay, I'm going quickly, but this is just to give you a bit of a signpost. Okay, so bone anchored hearing aids. The key thing is that one should consider bone anchored hearing or bone conduction hearing implants when someone is unable to successfully use conventional air conduction hearing aids. So microtia is one good example of that, in that you can't easily put a conventional hearing aid on a microtic pinner. Okay, but it's worth understanding some of the other reasons why someone might not be able to wear a conventional hearing aid. And in terms of bone conduction devices, you have non-surgical solutions worn on headbands, and then you have surgical solutions which can be divided up into percutaneous and transcutaneous. Okay, and at any one time there'll be a different selection of implants. So right now we have Bone Bridge, Osia and Sentio are the transcutaneous options, but that sort of changes all the time. It's worth just being aware of some of the reasons why someone would choose percutaneous and someone would use transcutaneous. And then don't forget there's also a middle ear implant which has a floating mass transducer that clips onto the ossicular chain. So broadly speaking, you're using bone conduction devices where people can't wear hearing aids, and also to reroute sound from an ear that is profoundly deaf. Okay. It's probably not going to work when a patient's more in cochlear implant territory in terms of their bone conduction thresholds. And you also want to be thinking about skin problems that can arise from bone anchored hearing implant surgery, and any conditions that might make osseointegration less favorable. It's also worth knowing the different components. So in a bone anchored hearing implant that's percutaneous, you have a fixture connected to an abutment connected to a processor. So that's how it works. So 3 components, and the processor has a microphone and a processor and a vibrating component all built into that unit. Okay, good. Well, let's keep going. So here's another question that can sort of throw you off. What is tympanometry? I mean, what is tympanometry? We all know what tympanometry is, but can you put it into words? Tympanometry is an objective measure of tympanic membrane compliance using reflected sound. It's almost worth just learning that phrase so that if you're asked, you can just reel it off and not get yourself entangled. What is in a tympanometer? Well, you've got a loudspeaker and a microphone and an air pump and you use the pump to obviously it's automated nowadays, but to create different pressures and then ping sound against the audiogram as a way of measuring middle ear pressure compared to atmospheric pressure. It's worth knowing some of the numbers that define type A and type C so that you're not caught out by that. And obviously this might lead into a question about otitis media with effusion. So most of you will probably know there's new NICE guidelines that came out in 2023. So just be aware of those. There's some updates in terms of being able to offer grommets for unilateral glue ear, the use of bone conduction devices, and not having to strictly stick to the 3-month rule if a child is having significant functional impact. Be able to talk about the role of adenoidectomy. Again, that's in the NICE guidelines as well. And also just be aware of the management strategies for special cases where you're expecting more chronic eustachian tube function. So glue ear, cleft, history of cleft. The guidelines are pretty vague, but the thing to consider is that you're expecting, unlike with a non-syndromic child where you might put grommets in, they fall out in a year, and the eustachian tube function is a year older and a year better. With children with these conditions, you're expecting more longer-term eustachian tube dysfunction. And so that might still be a reason to use grommets, but it might also be an argument for not leaning on grommets, but instead thinking about T-tubes or bone conduction devices and implants. Okay. Acute otitis media, be able to reel off a Viva like this very quickly, be able to explain the risk factors for recurrent acute otitis media and the management dilemmas. It's worth just knowing the evidence around when to give antibiotics immediately and when to give a delayed prescription of antibiotics. So, particularly under twos, bilateral disease, otorrhea, or any signs of extracranial complications should all obviously get more urgent antibiotic therapy compared to those presenting as a sort of regular viral otitis media. Okay, but you could easily get a question like that because these are the sorts of topics that come up, not the sort of crazy rare questions. Okay, it's also worth being really good at describing an audiogram. Okay, and again, this is a sort of thing where if you haven't practiced, you can easily take too long to describe an audiogram findings that you clearly know what it is. So this is a pure tone audiogram showing the air and bone conduction thresholds for a right ear. This demonstrates a conductive loss at around 45 decibels with a Carhart notch centered at 2 kilohertz with otherwise good preservation of bone conduction thresholds, indicating good inner ear function. I mean, that's an answer that sort of shows that you know what you're talking about and hasn't taken too long. So be able to describe an audiogram succinctly. In the case of otosclerosis, you want to be thinking about this when you get a normal otoscopic findings and a conductive hearing loss. In fact, normal otoscopy and any air bone gap should make you think of otosclerosis. And it might be worth being able to explain Carhart's notch. If they talk to you about sort of management of otosclerosis, just be aware of how to take a proper history in terms of ruling out other possibilities, so recurrent infections, trauma. Good to understand about vertigo to help you understand whether you would offer surgery, and ask about occupation if this is a clinical station. Obviously, the differential for otosclerosis are around ossicular discontinuity or tympanosclerosis, so fixation of the whole ossicular chain, and then beware of hidden cholesteatoma and also superior semicircular canal dehiscence, which can give you a pseudo air bone gap. Okay. All still okay so far for pace? Just if someone could just give me a thumbs up just to check that this is still okay. Great. Okay, super. I'm happy to take questions at the end as well. Okay, tuning forks. It's worth understanding like your reasons for doing CT scanning, and in terms of counselling for treatment, this is an area where you really want to be able to consent someone properly. You want to be able to quote, if not your own figures, the figures in the department you've had experience working in, and be aware that bone conduction devices are also an option for this condition. And they might ask you about contraindications. So obviously, in order to do stapes surgery, you need to have a malleus and an incus, and if you don't have that, then you might have to think twice. Active infection, and if that's the only hearing ear, you might also sort of reconsider the risk benefit as well. Everything else is sort of a relative contraindication. So yeah, but have a look at that when you're studying, and just be clear on what are the absolute contraindications and what are the relative contraindications. Okay, cholesteatoma. So you want to be able to explain this succinctly. What is cholesteatoma? It's keratinizing squamous epithelium within the middle ear. Boom. You've kept it succinct, and then it can obviously either be congenital or acquired. It's a clinical diagnosis. I would examine this patient under the microscope, paying particular attention to whether I could see the limits of any retraction, and whether there's any keratin accumulation. And I would supplement this with audiology and cross-sectional imaging as appropriate. You might get asked why you would use a CT scan in middle ear disease. Now, so obviously we've grown up through a generation where obviously you'd get a CT scan with before you're doing any tympanomastoid surgery. But believe it or not, there was a time when people didn't get scans actually. And so it's worth just being able to explain what are the things you're looking for, because a CT scan won't tell you whether someone has cholesteatoma or doesn't. You're not doing it for that reason. It won't necessarily even definitely tell you the extent of the disease. But what it will tell you, if you're planning to operate in the middle ear and mastoid, is how pneumatized the mastoid is that you're going to drill, how in the way the sigmoid is going to sit, how low the tegmen is going to sit, whether the nerve is dehiscent, and whether the jug bulb, carotid are dehiscent, and whether there's any coexistent inner ear breach. So you need to know that very clearly and be able to reel it off in an exam. You might get asked about what are the aims of cholesteatoma surgery. Obviously, it's to create a dry ear and eradicate disease, and also paying attention to potential for hearing reconstruction. And you might get asked about some of the merits and drawbacks of canal wall up surgery versus canal wall down surgery. And broadly speaking, canal wall up surgery, the aim is to preserve the anatomy and leave the patient with a more self-cleaning ear. The downside is that disease clearance might be more difficult, but certainly it's more difficult to identify a recurrence compared to if you're creating a mastoid cavity. It's worth just learning about this because I know there are quite significant geographical variations in the techniques that are typically used. Another classic question is, what are the factors that lead to an open mastoid cavity that never dries up? And it's basically these 6 things. So narrow meatoplasty, wide cavity, that can lead to a lot of wax and keratin collecting. High facial ridge, inadequate saucerization, residual disease, obviously, perforation of the neotympanum, or just the mastoid being very large. So yeah, being able to reel all those off. And then in terms of complications, you want to be able to discuss how you would manage different sequelae of cholesteatoma. So be able to discuss the risks of a labyrinthine fistula and how you would manage it intraoperatively, how you'd manage conductive hearing loss, how you would manage a facial palsy, whether it's partial or complete, whether it's immediate or delayed. And that's kind of a lecture in itself, but you should be able to find some book chapters that will explain all that. Okay, and then be aware of other extracranial complications of cholesteatoma surgery as well, and how to manage them. Good. Okay, so you want to look at an audiogram like this and kind of question spot. Okay, you don't want to spend a long time saying the X's are air conduction and the mask this, mask that. You just want to say this is a pure tone audiogram showing a bilateral symmetrical mid and high frequency profound sensory neural hearing loss, and then let the examiner guide you along the next question, which is probably going to lead onto a question about cochlear implantation. And so obviously if you work in a cochlear implant center, a lot of this will be stuff you know, but obviously you may not have worked in a cochlear implant center, in which case this is the sort of stuff you need to know. So cochlear implants have a role where conventional aiding, maximally amplified conventional aiding, is not enough to provide adequate stimulation for the brain to access speech and language in the ordinary situation. Now, there are situations where we implant non-verbal patients to give them access to environmental sound. But if you're aiming for a profoundly deaf child, a child who's been born profoundly deaf, if you're aiming for that child to learn language, then the early 4 to 5 years are very crucial in terms of brain language development. So we aim to implant children picked up through newborn hearing screening by around age 1. You can do it as early as sort of 6 or 7 months if parents are very motivated and the body weight is of a reasonable weight. But generally aiming for age 1, certainly by age 2. If you miss the boat and implant them after age 5 and they've not learned any verbal language, they probably won't learn verbal language. So this is why CIs need to be given within an MDT setting, because we're going to need lots of different specialties involved. Okay, it's worth knowing the components. So the external part has a microphone and processor and coil, and the internal part has a coil, receiver stimulator and electrode. So be able to explain that in a nutshell. And yeah, always reel off MDT, be aware of who is in the MDT and what they each do. And we have nice guidance for cochlear implantation in the UK, be able to explain what they are. So in adults, you need to have 2 frequencies between 0.5 kilohertz and 4 kilohertz that are 80 decibels or worse, and have speech discrimination testing that is within criteria as well. And it's AB words that is the speech discrimination test used in this country. In kids, we don't use speech discrimination, but we use the audiogram along with MDT assessment. Okay, good. It's also worth knowing about conventional hearing aids, okay, because they might easily ask you, what's the difference between a behind the ear aid versus an in the ear aid? What are the benefits and drawbacks? And in a nutshell, a way of explaining this is a hearing aid has a microphone and a loudspeaker. So it takes sound and delivers it more loudly into the ear. And the worse hearing is, the more you need to turn up the gain on that hearing aid. And the more you turn up the gain on a hearing aid, the more you have to isolate the loudspeaker from the microphone to prevent feedback. And therefore, in a severe loss, an in-the-ear aid is going to be more difficult, because it will be more difficult to isolate the microphone from the loudspeaker. And in more severe losses, you're going to have to use a more closed-fit molded aid rather than a dainty vented one. So those are the principles you need to understand. It could easily come up in a clinical station or a communication skills station. Okay, then we're getting into sort of more rare stuff. So you want to be able to look at this and say, this is an otoendoscopic view of a right tympanic membrane. There is a vascular lesion visible through the tympanic membrane in the inferior aspect, and my primary differential is that of a vascular tumour such as a paraganglioma. Okay, so loads of people talk about glomus tumours, so that's outdated nomenclature, because paragangliomas are the broad term for 4 different types of tumour, which include glomus tympanicum, glomus vagale, glomus jugulare, and carotid body tumours. Okay, so these are autonomic nervous system tissue vascular tumours, and they're derived from neural crest cells. There are 4 types, and their blood supply is from the ascending pharyngeal artery. So glomus tympanicum is centred in the middle ear. Glomus jugulare spreads a bit further, and obviously it can have a relationship with the major blood vessels going through the neck and the vagus nerve, and symptoms are according to that. So you can have a conductive hearing loss, pulsatile tinnitus, a mass in the ear of the neck, and it can give you cranial nerve palsies, which may need the attention of speech therapy to manage aspiration and dysphagia. It's worth just being aware of some of the differentials: hemotympanum, acute otitis media, aberrant carotid artery. Don't get too bogged down in all of that. Just get to the answer quickly is my advice if you get one of these. Again, classifications. So Fish is the most common one. Glasscock-Jackson also. Just be aware that they exist. I think it's unlikely they're going to ask you to classify tumour. And certainly if you get asked that, you're doing really well. But don't get too bogged down in trying to remember this at the compromise of actually delivering a slick answer. The key thing to say is that paraganglioma should be managed in a skull-based MDT. There are reasons to undertake genetic testing because of the associations with various genes and multiple endocrine neoplasia syndromes, and so therefore they may also screen families. And in terms of the investigations, you should know that the MRI has a salt and pepper appearance on T2, and a CT scan may also show the extent of bony destruction, and sometimes PET scans are used to exclude synchronous tumours. If you know all of that, you're doing pretty well. And management can essentially be divided into conservative, radiotherapy and surgery. It will often depend on patient symptoms, particularly around cranial nerve palsies, and surgery may involve preoperative embolization. It may involve subtotal resection as opposed to total resection. And again, it depends on whether you're trying to preserve cranial nerve function or not. The key thing is that it's all managed by an MDT. Okay, right, we're doing all right for time. I think we are, aren't we? So retractions can really floor you in the exam, because the examiner can just take you either way and convince you out of the answer you've given them. Okay, so let me just give you a few sort of tips on this. So this is an otoendoscopic view of a left tympanic membrane, and there is global retraction of the pars tensor onto the cochlear promontory and the incudostapedial joint and stapedius muscle. So be able to sort of deliver it like that. Now, when you're looking at these retractions, you want to be paying attention to whether the incudostapedial joint is intact, because that will help you to answer questions about what the audiogram might be like and what the management options might be. So in terms of assessment, you want to be able to establish, understand the patient's age and what's happening in their other ear, to build up a picture of what their eustachian tube function is like now and what it has been in previous years. You want to consider the degree of retraction, whether it inflates on Valsalva maneuver, whether there's any evidence of evolving cholesteatoma, and also what symptoms the patient is having. So this patient may not have any symptoms at all. Their hearing might be intact. They may not have any infections or discharge, but they may have hearing loss, feeling of pain, fullness, otorrhea. Don't forget to mention assessing the postnasal space, and then be aware of some of the management dilemmas. Okay, so conservative options include keeping the ear dry and using a hearing aid, and communication mitigation strategies to mitigate for very mild losses. You might also think, is the middle ear ventilation salvageable, either with a grommet by treating the nose or with Valsalva maneuvers? And if there's a permanent conductive hearing loss, maybe there might be a role for tympano-ossiculoplasty to lift up the eardrum, strengthen it with cartilage, and potentially repair the ossicular chain with titanium prostheses or cement. And obviously, in more recent years, we've had the advent of balloon eustachian tuboplasty as well, which we're still understanding the role of it in this. You might choose to sort of know a classification system for this, but again, I wouldn't get too bogged down with it, to be honest. And the other thing to do before the exam is just sit down with your local friendly audiologist and get them to show you how they do an audiogram. Like, just ask them to show you how they do a pure tone audiogram. And by doing that, you'll start to understand masking. So when you need to mask the non-test ear, and what is interaural attenuation, and when it's difficult to mask. So when you've got a bilateral conductive hearing loss, masking is difficult because the masking sound has to be played so loudly that it's very difficult for the test ear not to pick up the masking, and that's what we call the masking dilemma. And there are three rules for masking: essentially conductive losses and asymmetric losses. You're most likely to mask, but for the purposes of the exam, you just need to be able to reel off basically what's on this slide. So just learn it, and then if you get asked, you won't get caught out. Good. That is 45 minutes. So I'm going to pause there and invite questions, but hopefully that's been helpful to you. I'm conscious that there's a whole range of experience from medical students up to consultants on this call. So I hope I sort of pitched that reasonably well.
Thanks very much, Joe. That was very, very good. I've certainly sort of added a few notes to my own personal notes as well. We have a couple of questions related, first of all, to otosclerosis. So someone's asked, can we use BAHA as a first-line option for otosclerosis?
Okay, so the important thing when you're counselling someone with otosclerosis is that you need to be able to offer them all options, right? And so as a minimum, explain conservative options and things you can do to lighten listening effort in terms of communication tactics. Then the next tier on the ladder would be a conventional hearing aid, and you'd really only use a BAHA if the patient couldn't use a conventional hearing aid well. Now that might be because they've got recurrent otitis externa, or because they've got such a mixed loss that actually a conventional hearing aid isn't going to be loud enough. Would you use it as a first option? Probably not, but you need to be able to offer it to the patient to give them to make it their first option. You might then be asked, well, what are the downsides to a BAHA over stapes surgery? And the answer is probably going to be sound authenticity. So stapes surgery rectifies natural hearing, whereas conventional hearing aids and bone anchored hearing aids are using digital amplification of sound. So sound authenticity is going to be imperfect.
Great, thanks. So next question is, what is your approach for cholesteatoma if there is a lateral canal fistula?
Okay, so you obviously the risk of a dead ear or profound sensorineural hearing loss is much higher, and so you need to counsel the patient appropriately. The approach otherwise is not too dissimilar in terms of surgical technique, but with a few specific things. You want to avoid, you typically might leave if there's cholesteatoma over the fistula, you might leave that towards the end. You want to avoid using direct suction on the fistula, but the general wisdom is to gently try and peel away that cholesteatoma, and then there's a decision to be made about whether to cover it with something. Usually I'll put some fascia, on the few times I've done this, put some fascia over the fistula and something else to support it, like cartilage or bone pate. You might read in the textbooks guidance to use canal wall down mastoidectomy for this. I don't think that's necessarily subscribed to anymore.
Great. So with regards to opening statements, you mentioned about being succinct and brief. So should you offer a diagnosis and or multiple differentials in that opening statement, or do you potentially risk offering wrong diagnosis or inviting questions in your differentials that really stop the Viva from progressing?
Yeah.
What would be your
good question.
Suggestions for that?
Yeah, really pertinent question, and I think probably if you feel obviously confident at what you're looking at, then yes, go ahead and say what you think it is, and let them interrupt you to ask the next question. Yeah, the danger is that you go off on the wrong track, and it is very much in the mark scheme that you can't progress on to the later questions if you don't get past the pass-fail question. And I remember in my Viva, I got caught out with this, where it was a question about pediatric hearing loss, and child fails newborn hearing screening. They get referred. What's the next step? And I kept on going on about the later steps. And what they wanted me to say was you'd repeat the ABR. And, you know, I wasted like a good minute or two not saying that. So I think all you can do is like aim for the good marks by giving your very succinct opening, and you know, if it's an obvious diagnosis, say it, and say in a nutshell what you would do. But if it's clear that you've gone down the wrong track, let them help you recover, I think. But the reason I say be succinct and give your diagnosis is because you do want to sort of get through the pass-fail question pretty early on. And if you start giving a long-winded answer about how you would take a history, and you would ask about hearing loss, and you would ask about tinnitus, and it's clearly cholesteatoma, I think you want to sort of try and get to the higher marks early on.
Yeah, I think I'd agree with that, and also I think one thing to bear in mind is when you come up with differentials, make sure they're genuinely differentials. I think one sort of exam tip is don't say anything, you know, which is obviously wrong, or kind of, you know, it's obviously not going to be that. So I think that is a potential risk. You want to mitigate the downside, say sensible things, and kind of move on. Good. So how can you explain the mechanism of Cahard notches in simple terms for exams? So I think you've kind of done that, really. That's your second bullet point, probably, there.
It's on the screen, but let me try and explain it to you in my own words. So the measurement of bone conduction.
Oh, the mechanism,
yeah. So the mechanism of the measuring of bone conduction includes a contribution from the ossicular chain. And so if the ossicular chain is defective, it leads to an artifactual apparent reduction in bone conduction, because you're not getting that contribution of the ossicular chain itself to bone conduction. And so when you correct that, you then see a correction of that artifact. That's my sort of layperson explanation of it. Hopefully that's helpful.
Great. Another question about fistula. So I suppose, so for an inexperienced consultant who faces fistula, I assume this is sort of lateral canal fistula. Intraoperatively, how should I act? Is there any kind of anything you would add to what you'd kind of mentioned before?
Okay, so it depends on whether this is the exam or real life, right?
Yeah.
So I think in the exam you can say, you know, ideally I would anticipate this preoperatively with scanning, but if I encountered it intraoperatively and felt I didn't have the required experience, I would simply stop and close and counsel the patient and involve a senior colleague, right? And I think that's you can say that in the exam, and then if they push you on what should be done, then I think you have to answer the question. In real life, it's probably the same, really. I mean, ideally, if you're inexperienced at cholesteatoma surgery, ideally you're not doing this sort of case. But if you mean inexperienced in the sense that you're an otologist that just hasn't seen many fistulas, then yeah, I think my answer would be what I said earlier, which is meticulous dissection, avoid direct suction. Yeah.
I think it's always useful, isn't it, in kind of to think about these scenarios, not only for exams, but you know, in general, I suppose, in clinical practice, and having an answer in your head for the exam as well as in clinical practice. I think it's quite useful, because looking at the you know, the most recent mark schemes, I think the word confidence has been mentioned about half a dozen times, or 6-7 times. So it is actually quite subjective. So if you show you're confident and you're not umming and ahhing when someone asks you, you know, is there a fistula, or so on and so forth, I think that's probably quite quite useful to have an idea in your head, even if you are probably, you haven't had that much experience dealing with these. Okay, so in terms of other questions,
Glasgow benefit plot. Okay.
yes.
So the Glasgow benefit plot and the Belfast rule of thumb sort of say the same thing. Both of them aren't really used by otologists, certainly in this country anymore. I think it's a sort of outdated view in an era where it was either, where there was no role for hearing aids in a there was no consideration of the fact that actually improving your hearing enables you to wear a lighter, daintier hearing aid and therefore has benefit. But essentially what both of them say is that for a patient to perceive quality of life benefit from ossicular surgery, you need to get the hearing to within 15 decibels of the other ear or better than 30 decibels at all. In a nutshell, that's what they mean by that. Masking rules. Oh, Livy, I mean, there's a question. I mean, do you know what? Probably, I probably could have explained it at one point, but probably the best thing to do is ask an audiologist to explain it. What it means is, the question is, when do you have to use masking? Okay, because why not use masking? Well, masking is it takes more time. It's more labor intensive. Okay, and so that's why these rules exist, because you don't have to mask all the time, but you have to mask in certain situations. And so rule 1 states that if there's an asymmetry of actual hearing of 40 decibels, then mask the non-test ear. Okay, so any asymmetric loss greater than 40 decibels, mask the better ear. Okay. Rule 2 is basically sort of any conductive hearing loss, basically. And then the rule 3 is the hardest one to differentiate. But yeah, greater than 40 decibel difference between the worse ear air conduction and the better ear bone conduction. So yeah, that's that basically.
I think the numbers come from interoral attenuation, don't they? That's where there's sort of not just random numbers 40 and 10 for air and bone. And I think it depends whether or not you have inserts and whether not inserts and so on.
Yeah. So if you're wearing headphones, you can consider that if you play a sound at 40 decibels, it's going to be captured 40 decibels quieter in the other ear. Yeah. And so you can work backwards from your audio.
That's basically where they come from. Autoimmune inner ear disease. How do you manage?
Okay, so you can say in conjunction with a rheumatologist. How do you diagnose autoimmune inner ear disease? Well, it's fluctuating sensory neural hearing loss bilaterally, should make you think about it. There's no actual standardized protocol on how to manage autoimmune inner ear disease, but you might talk about taking a history, a systems history that helps to point to any autoimmune diseases. And you might know a few autoimmune diseases that feature hearing loss, Kogan's and whatnot. You might be able to talk about some of the bloods that are done and some of the management strategies, which might include prednisolone for a month, might include immune modulating drugs such as methotrexate and azathioprine. And obviously some of these patients end up needing cochlear implant surgery as well. That's probably all you need to know and say.
Great. So got probably time for one more question, possibly two.
Okay.
Do you want a question on bone conduction hearing implants, or do you want a question about malingering?
Let's go for the bone conduction implant question.
Okay.
So if you here, let me find there's another give me a second. Let me let me just pull up another slide. So if you really want to know the answer to this question, you can just have a look at this, which is a slide I actually show all my patients, explaining the dilemmas between percutaneous bone conduction implants and transcutaneous implants. And this is actually on YouTube if you want to go and watch the video, which basically answers that question. So so that's that one. Are they likely to give you a question about malingering? Yeah, so if some of you use my pink textbook, there's a chapter on non-organic hearing loss. Just have a read of that. But it's worth knowing. You need to be able to spot an audiogram that looks like a non-organic hearing loss audiogram, and it's usually where the masked bone conduction in the worse ear is much lower than you expect it to be. Or the unmasked bone conduction is worse. And you might want to know about how Stenger's test works. Yeah, so that is a question that could come up. Yeah. Ear canal atresia. If you heard what I said about microtia, same sort of stuff. Does pure conductive hearing loss affect your choice of bone conduction implant? So different bone conduction implants have different criteria for which the BC levels need to be. In a pure conductive hearing loss, the question first should always be, can I close the air bone gap? So if I can close the air bone gap, I should always explore that first. Then, can they wear a conventional hearing aid? Then, should I use a bone conduction device? And if so, which one? That's the order of thinking.